So, welcome everyone, panelists and attendees, to another fantastically organised webinar from Thrombosis UK. I'm Dan Horner. I'm an emergency physician and intensivist from Manchester. And I'm very grateful to be given the role of chair today because we're talking about what happens when people get better, really, from COVID-19 and what happens when they leave the hospital and some of the problem areas around thrombotic risk in the community and how to manage it, which is very much outside my area of expertise. So I shall do my best to get the most out of our experts on the panel. We've got over 500 people registered for today's webinar, which is great. Lovely to see so much interest and ongoing enthusiasm about sharing knowledge and expertise and experience in this challenging illness and talking about the ongoing developments in the evidence base. So thank you again to Joe and Thrombosis UK for organising and facilitating this. A few quick notes to say this webinar is being recorded, so it will be made available at a future time point to recap. There are certificates available for your portfolios. If there are questions about those, Joe can field them. We've had some excellent pre-registered questions, which we will try and build into the discussion section of the webinar in the later half. But please use the chat function and the Q&A function if you have topics that you would like us to address or that you think are particularly relevant that we haven't covered. And I shall try as chair to build them in and direct those to the panelists as appropriate. So we shall get cracking. And our first presentation today is from Professor Beverly Hunt, who's going to discuss the natural history of COVID-19 and COVID pneumonia, looking at really what we know about the timing of this illness in terms of development of pro-thrombotic state and what we know about the evidence so far. Professor Hunt needs very little introduction, but in brief, she's Professor of Thrombosis and Hemostasis at King's College and Guy's and St Thomas's in London. She's a national and international expert in thrombosis and acquired bleeding disorders. She sat on multiple national and international guideline writing groups of particular relevance, both the ISTH and the recent NHS England guideline writing group, looking at producing guidance on how to manage thrombotic risk in COVID-19. She's got extensive clinical experience of thrombotic and acquired bleeding disorders, runs a very active research group, and is also medical director of Thrombosis UK and chair of the steering committee of the World Thrombosis Day. So great to hear from you, Beverly. Thanks very much.
Okay, so it's my job really to set the scene and to remind everyone about COVID-19 pathogenesis. So just to remind us all that COVID enters the body and binds to ACE2 receptors to get entry into the body, and they are widely expressed on the pulmonary epithelium. There is that enormous surface area of the lungs. But within the body, they are also present on the endothelium, they are on monocytes, macrophages, lymphocytes. Platelets will actually carry the virus, although they don't have receptors, and also present on myocytes and adipocytes. So luckily, for most people who have COVID, they have a more mild infection, so they may actually be asymptomatic, or they may have 7 to 10 days low-grade fever, shortness of breath, or anosmia only, and then they get better. The issue, especially for the British population, is that we have those who go on to get COVID-19 pneumonia. And we know that their premorbid conditions are increasing age, obesity, diabetes, and cardiovascular disease. And they are highly prevalent in our population. And also we have got quite an old population compared to the rest of the world. The effect of the pneumonia is to induce a massive inflammatory response. So that's innate immunity and also T cells. And there is an incredible cytokine storm, macrophage activation. And these patients are short of oxygen, and we admit them to hospital for that very reason. Some only require oxygenation, and we call those moderate. If they need mechanical ventilation, then they have severe COVID. And the issue for all of us, and really probably why we're here today, is that that amazing inflammatory storm engenders a prothrombotic state. So we know that the IL-6 levels correlate with the very high levels of fibrinogen that we see. So we have to look and think about when is the VTE risk increased in COVID infection. So if we think about a patient's journey, they might get infected, and confining this conversation to those who have severe COVID, they will be hospitalized, and they have a risk of hospital-associated VTE until 90 days post-discharge. And we know that 60% of hospital-associated VTE occurs post-discharge. So we are expecting to see these patients coming in from the community. What we don't know is after that 90 days, what might be going on. So we know that we have late sequelae with COVID now. So we have had a splatter of publications about COVID fingers and toes, which can occur weeks after people have had initial infection. And also we have the issue, which is becoming more and more apparent, that some of the patients who have very prolonged periods on ventilation and have very damaged lungs, that they may need long-term oxygenation. And of course, if you have a long period on a ventilator, you need a long time of rehabilitation because you have lost muscle mass. So where have we got increased risk? Well, I know we're going to discuss those who don't come into hospital, but who may be at home isolated. I think that there is risk associated around immobility and dehydration, and it's unclear what the risk is after 90 days post-discharge. What's also going on is that we aren't admitting everybody. So I've had conversations with people who've been really sick at home, but have been terrified of going to hospital, and you suspect they probably did have COVID pneumonia. And also those who are in care homes who will have that same profound prothrombotic state. So the question is, what is their risk, and should we be giving them thromboprophylaxis? So just a reminder of the changes. This is our data. There are other people who have produced their data. So this is our first 66 patients in critical care. Just to remind you how high those fibrinogens are. So we're talking about a median fibrinogen of about 7 or 8. And we've seen people as high as 14 grams per litre. And of course, their factor 8 and their von Willebrand factor also very high, and their fibrolytic activity is damped down, as though they had very high levels of D-dimer. And just to point out, this D-dimer scale is logarithmic. So we've got incredibly high levels of D-dimer, which I would argue are probably spillover of fibrinolysis occurring in the lungs as a reaction to the lung injury rather than coagulation. And then we've got the other markers of inflammation, procalcitonin and ferritin and CLP at the bottom, showing again very high levels, and they correlate beautifully with fibrinogen. And then the other issue that makes life that much more complicated for severe COVID is that we've probably got two pathologies going on in the lung. So we've already discussed hospital-associated VTE, but we've also got immunothrombosis going on in the lung. What do I mean by that? In that we have areas of profound inflammation and we are getting local pulmonary thrombosis in the microvasculature. We know that thrombosis is an endpoint of inflammation, and we are probably picking these up as segmental or subsegmental lesions on CT pulmonary angiography. So some brief mention of the guidance. So NHS England commissioned a multidisciplinary group to produce guidance for the management of patients with COVID. It was submitted to NHS England on the 22nd of April, and after a lot of whipping and beating, it's finally been published on the 18th of June on some hidden website. and it's sponsored by the Royal College of Anaesthetists and the Royal College of Physicians, and I challenge you to find it because it doesn't come up on Google necessarily and needs more publicity, and we can send out copies to anyone if they email us, and it will be on the Thrombosis UK website too. And then lastly, we've got ongoing research about thromboprophylaxis in COVID. Now, we've had a very poor response from the authorities. So when you want to do research in COVID, you have to submit it and get it approved by the Chief Medical Officer and the NIHR, and they have rejected all the randomized controlled trials, but they have asked that the platform trials would start doing research into thromboprophylaxis in COVID. So Recovery, which is looking at the patients on the wards, didn't want to do any trials in thromboprophylaxis, but they're very interested now. And of course, they've yielded this amazing information that dexamethasone reduces mortality in those with severe pneumonia by about a third, which is absolutely astonishing, very exciting. And all the patients who enter critical care will be starting dexamethasone. REMAP-CAP is the trial looking at those in critical care. We introduced an anticoagulation arm about 2 or 3 weeks ago. So far, 70 patients have been randomized to this. And at the moment, we're looking at an antiplatelet arm using various antiplatelet agents, and it's still in the design phase. Thankfully, the number of cases in the UK is very small, and we expect that REMAP-CAP and Recovery will be taken up in Mexico and Brazil, where there's very high rates of COVID at the moment. So that's me done, just to open up things. Thank you.
Thank you, Beverly. That's a wonderful introduction to the timeline of COVID-19 and some of the issues associated. I promise I won't tell the Faculty of Intensive Care Medicine that you think their website is unfindable.
You can't find it. If you put in thromboprophylaxis guidance in Google, I couldn't find it.
Yeah, it's challenging. There's a specific repository called icmanesthesiacovid19.org, which is where the Royal College of Anaesthetists and the Faculty of Intensive Care Medicine is trying to cohort all its guidelines. I agree that's not the best place.
It's not well known to hematologists, I'm afraid.
Yeah, well, lucky we've got a multidisciplinary panel, so we can all share our expertise and information. But I've tried to already post a link on the chat. I will make sure that something else comes in there so that you can all access that guidance and have a good look at it, because it is very interesting to read. Thinking then about the natural history and the timing of prothrombotic risk in COVID-19, it's my pleasure to introduce Dr. Susie Shapiro, who will be giving our next talk. And Susie's going to talk about what evidence we have already to guide our decision-making when considering extended thromboprophylaxis in the community, and especially with regard to COVID-19. Dr. Shapiro works entirely in the field of hemostasis and thrombosis across haemophilia and other bleeding disorders, and until recently was the Oxford University Foundation Trust Lead for both thrombosis prevention and anticoagulation. She's the current director of the Oxford Haemophilia Centre and has a particular interest in improving patient safety with projects to optimise anticoagulation, winning national awards. Her research interests complement her clinical work. She's an MRC clinical fellow investigating cancer associated with thrombosis. She was with us for the last webinar and gave a fantastic talk, and I'm looking forward to hearing what she has to say about extended thromboprophylaxis. Over to you, Susie.
Thank you, Dan, and thank you Thrombosis UK and Beverly for asking me to participate again in this webinar. So, as has been alluded to, in the last month, there has been a wealth of guidelines around VTE and COVID, including around extended thromboprophylaxis. So what I'd like to do in a few slides is just initially highlight the main guidelines and their recommendations with regards to extended thromboprophylaxis in this group of patients, and then look at the evidence base underlying the recommendations. So the International Society of Thrombosis and Hemostasis, ISTH, published guidelines on the 27th of May 2020. The American College of Chest Physicians, ACCP, published their guidelines less than a week later on the 2nd of June 2020, and the UK national guidelines were finally published on the 19th of June. And they are very difficult to find. I owe finding them thanks to Beverly sending me an email, but at the bottom of this slide is the website where you can find them. So the ISTH guidelines, to begin with them, they recommended that in this group of patients, so patients who have been admitted with COVID, medical inpatients, on discharge should be considered for extended thromboprophylaxis if they were considered to have low risk of bleeding and high VTE risk. So they've defined a high VTE risk as those being with advanced age, an ICU stay, cancer, prior history of VTE, thrombophilia, severe immobility, D-dimers more than twice the upper limit of normal, and an improved VTE score of 4 or more. So it's fairly wide ranging. For anyone who's not familiar with the improved score, it's a validated VTE risk assessment score. People can score between 0 and 10, and the higher your score, the higher your risk of VTE. So for this group of patients, ISTH recommend that you consider extended thromboprophylaxis with either low molecular weight heparin or a DOAC, and for 14 to 30 days. A few days later, the ACCP published their guidelines, which said, based on the currently available evidence, extended thromboprophylaxis is not recommended in this group of patients. And then the UK guidelines say that thromboprophylaxis may be considered in this group of patients, those who are considered particularly high VTE risk, which is suggested of those following an ICU admission or reduced pre-admission mobility, and that if you're going to give it, then give low molecular weight heparin for 14 to 28 days. So there's obviously significant discrepancies within them. And so what I'd like to do is take us back to the evidence base for extended thromboprophylaxis in medical inpatients generally, and then see how we can apply that to patients with COVID-19. So for extended thromboprophylaxis in medical inpatients, there have been 5 large randomized controlled trials, which are listed here. So Exclaim trialed enoxaparin as an inpatient with additional enoxaparin compared to placebo for 28 days on discharge. Adopt, Magellan, and Apex trialed low molecular weight heparin as an inpatient compared to a DOAC started as an inpatient and then continued for between 30 and 42 days. And Mariner gave everyone low molecular weight heparin as an inpatient, but then on discharge randomized them between rivaroxaban and placebo for 45 days on discharge. So this figure is taken by from a review which is listed here. And on the y-axis, it looks at event rates in patients, the red ones being bleeding, the blue ones being VTE. And on the x-axis, it's got all the patients are compared by treatment arm in each study. The colors don't necessarily come out very well, but I'll try and take you through it. So in red, the brighter red is any bleeding, with the darker red being major bleeding. So this is enoxaparin compared to placebo, apixaban compared to placebo. And as you can see, in all arms given extended thromboprophylaxis with an anticoagulant, there's an increase in bleeding compared to placebo, which you would expect. With regards to VTE, these first 4 trials did screening looking for asymptomatic VTE. And so the dark blue is proximal DVT, whereas the smaller, lighter blue is symptomatic VTE. And this is those on the left who received the anticoagulant extended compared to those who didn't, and there's a reduction in risk of VTE as well. So there's a meta-analysis of these 5 trials, which has shown that overall the extended thromboprophylaxis reduced the risk of symptomatic VTE or death from 1.2% to 0.8%, so approximately 40% reduction. However, it doubled the risk of major or fatal bleeding from 0.3% to 0.6%. So the number needed to treat for one symptomatic VTE or VTE-related death was 250, with the number to harm one major or fatal bleeding event, 333. So arguably that is quite close. So how might one find the group of patients who are at highest risk of VTE and who might benefit the most from extended thromboprophylaxis? So there was a post hoc analysis of the Magellan trial, which had used rivaroxaban as an inpatient and extended it, that tried to do just this. So they tried to select a group of patients who they considered at low risk of bleeding, but at high risk of VTE, based on a modified improved score of 4 or more, or 2 or more with high D dimers. And this subgroup ended up being about 56% of the full patient cohort, so 3,654 patients altogether. And they found that in this group of patients, the VTE rate at 35 days was 7.9% compared to 2.8% in the lower VTE risk group. So they found a subpopulation with the VTE rate post-discharge that was 3 times higher, and suggest that this subgroup of patients might benefit from extended thromboprophylaxis. However, this similar subgroup of patients was trialed in the Mariner trial, looking at rivaroxaban post-discharge. So the Mariner trial, the eligibility criteria included the modified improved score of 4 or more and the improved score of 2 or more with elevated D dimers. And it didn't find a significant reduction in symptomatic VTE or death of VTE, or with major bleeding with rivaroxaban, but there was a significant increase in clinically relevant non-major bleeding. So I'm not sure that we have yet found the balance of the highest risk group patients who would benefit from extended thromboprophylaxis in general. So how about with COVID? So ACCP did an analysis for the patients with COVID-19, and they've said if the risk of symptomatic VTE is more than 1.8% at 35 to 40 days following discharge, then there would be a net benefit of extended thromboprophylaxis in patients with low risk of bleeding. The reason they have currently not advised to give patients extended thromboprophylaxis is whilst there is concern that hospitalized patients with COVID appear to have an increased risk of VTE compared to what we might expect, no one has yet published data on VTE risk or bleeding risk post-discharge. So it is an unknown. And so that, because we do not have that data in either observational published data or a randomized controlled trial, that is why expert consensus opinion between the international guidelines varies. And on that note, I will stop. Thanks, Dan.
Thank you, Susie, for an excellent talk that I'm sure is going to generate some discussion and questions. 3 guidelines, all slightly different, what to do. I think, I'd like to start by talking a little bit about the question and the practice of thromboprophylaxis on discharge following a hospital stay. So we can always come back later if needed to what happens during hospital, but let's assume that a patient has got through their hospital stay and is ready to be discharged to a community setting. Can I ask you both in turn what your current practice is? I would assume that it would be easiest to assume a prothrombotic risk and to recommend generic thromboprophylaxis. It's a little bit harder to risk assess. If you are going to risk assess, what are you using? Susie, should we start with you?
Yeah, okay. So if I was left to my own devices at the start of COVID, my inclination was that we know standard thromboprophylaxis as inpatient works, and we don't normally give extended thromboprophylaxis, and to make sure we at least keep on doing that and do it really well, and try and recruit patients into randomized controlled trials ASAP. The difficulty has been that the randomized controlled trials didn't start to come out quickly. And within a few weeks, certainly by the end of March, myself and my colleagues were having almost daily, multiple calls each day saying, we're really worried about the VTE risk in these patients, surely we should be doing more. And so in the end, we got an expert consensus group together from across the hospital, including ICU, medics, ourselves, and we agreed expert consensus local guidelines, which were, with regard to extended thromboprophylaxis, we opted to do 7 days of low molecular weight heparin, which kind of, we debated doing more, we debated a DOAC, but we opted for the 7 days of low molecular weight heparin in everyone, because I think that unless you have evidence that further risk stratification is the right thing to do, it's simple to say everyone should have something. So that's what we did. And we debated changing it following the guidelines. But because now we're kind of sitting in the middle of all the guidelines, but we're going to wait a couple of weeks, because in a couple of weeks' time, we should have our local data to be able to properly analyse the rate following discharge. And so we'll look at our local data then and then decide.
So I think local data is important, isn't it? As we've seen from different regions around the country, you know, the incidence rates do differ. You know, do the complication rates differ? I think we're still awaiting that kind of data. Certainly, you know, giving one rule to everyone is the easiest way of getting things done, isn't it? Beverly, are you doing something different?
You're muted. Beverly, you're muted.
It was always going to happen once.
Sorry, I'm on call and I had to deal with something. So that there are two schools of thought, aren't there? So it would be lovely in these COVID times to base everything on randomized controlled trials, because that's how we normally operate. But we had this enormous influx of patients and a lot of critical care physicians on our backs saying these patients are really thrombosing. At the peak of the pandemic, we had 190 ventilated beds here on site, and a lot of people clamoring saying you're not giving enough thromboprophylaxis, which is so unusual because they're normally saying I don't want to give it. So the pressure was on, and it's back to old-fashioned observational medicine, and there does appear to be a higher rate of VTE, and then we're looking at these profound prothrombotic changes, and these patients are on critical care for weeks. So we have opted to give 2 weeks thromboprophylaxis post-discharge for all critical care patients. And if people have concerns for the ward patients, they can do the same. And we have asked that they use either low molecular weight heparin or a low-dose DOAC if there are issues with the patient being unable to give the injections. I think we have to be mindful that low-dose DOACs for extended thromboprophylaxis are used for medical patients in the States, and they do have an FDA license. They got turned down by the European Medicine Agency, not because they didn't have some positive effect, but because it didn't appear to be cost effective. So on that basis, we feel justified in using off-license use of low-dose DOACs. And that's really what the national guidance says as well.
Interesting. So I suppose to make the three of us all have slightly different approaches. Our consensus at the moment locally at Salford, where I work, is for a formal risk assessment, and we highlight the options available for extended thromboprophylaxis, but we are stopping short at the moment of recommending it based on monthly interrogation of our data, and of course you both as thrombosis leads and experts will have sight of your HATS rates presumably and your feedback mechanism, so you can look at this every month, can't you, and adjust. But it is interesting, isn't it, that we're all doing different things. I think if we talk about risk assessment briefly there, so at the point of discharge, clearly your guidance moves people towards thromboprophylaxis, but I would imagine there is an element of risk assessment in that decision, be it an estimate of bleeding risk, for example, or trying to quantify a thrombosis risk. And you talk, Susie, eloquently about the improved score and D-dimer cut points and ways in which the guidelines are trying to direct people towards identifying those patients at higher risk. What do you think about risk assessment at the point of discharge? Because we have a number of different scores. It's a subject very close to Beverly and my heart at the moment, because we're doing a research project at the moment on the clinical and cost effectiveness of the different risk scores used across the world. And we could be using the Padua, the Caprini, the Kucha score. There's the Department of Health risk assessment tool. We've talked about the Improve. We've talked about blood tests. You know, what do you think the role of risk assessment at discharge is? And do you think any score is better than a sensible senior clinician making a balanced decision with the patient? Susie, should we go back to you first?
So I think if we had the evidence to know the right thing to do, and if the evidence identified a specific subgroup of these patients, so that, for example, patients with COVID-19 who had been on ICU, whereas no one else with COVID meets the balance for extended thromboprophylaxis, then I would agree, you know, then that should be there should be a risk assessment on discharge with that as the reason for doing it. But I don't think that we are there. Like, we don't have the evidence whether or not we should give it or not, let alone which subgroup we should give it on. So then there's a balanced judgment, whether that's done overall in the trust. So yes, all of our patients none of our patients should really have thromboprophylaxis if they're considered at very high risk of bleeding. But otherwise, we made the decision to give everyone who had been admitted with COVID 7 days. It's not that I know that it's right, but I know that if we think that we should do something, or maybe doing something is the right thing to do, that can be fairly easily enforced across the trust. Whereas I think that as soon as you leave it to individual judgment, often by the junior at the end of the, you know, bed quickly doing a discharge summary, then how are they making that decision, and how much counselling is really being given to that patient?
I think that, you know, that's a great point. And there is subjectivity in a lot of the decision rules, aren't there? So if we applied a risk assessment tool, then would I get the same output as you would, as Beverly would, as a FY1 doing the discharge summary would? I think that's really challenging, and the different scores have different criteria in them, some of which are far more subjective than others. What about bleeding scores, Susie? If I just stick with you for a second, if we're struggling about the idea of calculating thrombotic risk in a quantitative fashion, and we think it would be easier to say everyone should get the same, what about that decision making around bleeding risk? Because surely the same junior doctor still needs to be able to think about that when they are prescribing extended duration thromboprophylaxis.
Yes, so it's a very good point. I guess our admission VTE risk assessment has a list of both VTE risk factors and bleeding risk factors, and that should be redone if any of those factors change. And so the list of the standard VTE risk, standard bleeding risk factors is still there. So at this point in time, I wouldn't change that for patients with COVID-19 because we don't have the evidence to do that. But the standard VTE risk assessment that we do on admission and should be redone as the clinical situation changes should also be thought about in discharge.
Yeah, so that just brings me on to one tiny interlude question, which is that, of course, NICE guidance has been explicit for years that we should be redoing the VTE clinical risk assessment whenever the clinical situation changes. Do you have any evidence that it is repeated in your trust? And if so, how have you managed to capture it?
That is incredibly difficult to do, and we've had multiple conversations about it. So the short answer is no. Yeah. So if someone's been in for more than 7 days, we reflag up the electronic, we've got an electronic VTE risk assessment. We can check that it's been done on admission. We reflag it up after 7 days. I think the reality is, what is most important is that the physician rethinks about it and redocuments it in some way, whether or not it's using the official form or not. But so I don't have a good way of checking, except for example, when we go back and look at the hospital-associated thromboses that may be potentially preventable, it's one of the things that we would look for.
Yeah, so we have a very similar setup. We've introduced tracking boards at Salford, and the HAT risk assessment column goes red after 7 days routinely, and we think of that as a middle ground between, you know, reminding people of the importance of regular risk assessment versus the impossible situation of trying to keep an eye on whenever the clinical situation changes for every hospitalised inpatient. It's very challenging, isn't it? Beverly, can I come to you about risk assessment? What are your thoughts on the different tools, both for thrombotic risk and for bleeding risk, and do you think they have any role in this kind of decision making?
So there is no validated risk assessment tool for post-discharge thromboprophylaxis, really, is there? I mean, I know that they use the modified improved tool, but in this setting, I don't think anything's of particular value. I think the most important thing is to make sure they haven't got a bleeding risk. And one of the other issues is that we have constantly changing care. All that time during the pandemic, the care was changing in every area of those patients' treatment. And we were redeploying staff from other wards who weren't used to critical care management to critical care. So we have training pathways. So it's so important to keep things simple. So if you just say, look, everybody gets thromboprophylaxis after critical care admission, providing they haven't got a bleeding problem, I think that's all we could do at that time. All our doctors have got action cards for all the different areas, and they've got stacks of them. And we must keep it simple for them. It's not fair to give them complex VT risk assessment when we've got no evidence that they're really going to help very much.
I think it's a very good point. I suppose the intensivist in me wants to, I suppose, challenge the kind of the singular risk characteristic of being an intensive care patient, because of course that can mean a huge variety of things. And if you translate that internationally, what does intensive care mean in America versus England? That there's slightly different cohorts of patients. And of course you can be in for 2 days, or you can be in for 2 weeks. You can then have a rehab period within the hospital that lasts 3 months prior to your discharge. The fact that you have passed through intensive care, you know, do you think that's where we should be setting the bar, just highlighting these risks?
Oh yes, I think having been on US intensive care, staying with friends, I know that you just have a little cough and you can end up in intensive care in the US, whereas here we have very strict criteria. Most of the patients are being ventilated. That's really the definition of admission. So there is some clarity, and I wouldn't apply what I just said about giving everyone thromboprophylaxis after critical care admission with COVID necessarily to the States. It's a very UK thing. We understand in the UK who we are admitting to critical care. Susie does, you do, don't you? I mean, we're hematologists, but we know when we go on critical care, we see rows of ventilators usually.
Yeah, and never more so during the pandemic, when we were trying to, of course, keep everyone else out of critical care. Okay, I mean, excellent discussion about risk assessment, really. If we then think about the agents that we are using, I can't help but notice that the NHS England guideline on the ICM website talks specifically about low molecular weight heparin, doesn't it? And it doesn't really mention DOACs. Whereas the ISTH guidance, I think, talks about the proportion of respondents that said they'd be happy to use a DOAC therapy, and you just mentioned it. And then we've had a good question from one of the attendees about the role for antiplatelet agents in this kind of prophylaxis, and we have seen them creep back into NICE guidance recently, obviously with regard to orthopedic surgery more than anything else, but they're an ongoing question, aren't they? So Beverly, if I come straight back to you to talk about agents, low molecular weight heparins, DOACs, antiplatelets, what are your thoughts on all three?
So low-dose DOACs in the trials, I think overall, especially looking at some of the scores they used, are probably, well, they're certainly, I think they have a slightly lower bleed rate than low molecular weight heparins. They're certainly easier. We don't have a cohort of district nurses to go into people's homes to give them low molecular weight heparin. So I think they're a viable alternative post-COVID. And we have so much discussion about how much the COVID patients don't tend to bleed. I'm not sure I necessarily agree with that, but the overwhelming problem is thrombosis. So I think we're happy to prescribe low-dose DOACs, and we will be getting data back on their bleed rates.
And what about antiplatelet agents?
So antiplatelet agents are an absolute no-no at the moment, I think, because the evidence for their efficacy in medically ill patients, which is what we're dealing with COVID, is non-existent. And we would definitely increase bleeding risk without actually having had increased efficacy. So I don't think so. We need to look at their effect on inpatients first, and then we need to do trials to look at them post-op. But I think no.
Can I ask what the intervention?
No.
I mean, that was a third no, yeah. Can I ask what the intervention is planned for REMAP-CAP, Beverly? So which antiplatelet in particular is being looked at?
So, well, it's my view that we need to offer options to people. So we are thinking about aspirin, dipyridamole, and ticagrelol. Clopidogrel interacts with quite a lot of the antivirals, so probably isn't an option. Because lots of people are using antivirals and some of the other arms. So that's really where we're heading. Okay.
Susie, can I get your thoughts on the different types of agents available? I think I got the impression you were focusing on low molecular weight heparin.
Yes. I think if your DOACs are much easier. I think if you're once giving 4 weeks extended thromboprophylaxis, then it's much easier to give it with a DOAC than with low molecular weight heparin. And so if we get evidence that extended thromboprophylaxis is the right thing to do and we should be doing it properly for 4 weeks, if that's the evidence, then I'd thought that it's much more straightforward and feasible to do that with a DOAC than low molecular weight heparin. And we stuck with low molecular weight heparin because we were currently only giving a week. And given there's not yet, and we said people should have it if they can self-administer it or if a family member can self-administer it, so we don't have district nurses going in. And we left it like that because there is currently no evidence whether or not it should be given. If I knew there was stronger evidence to do it, then I would have DOACs if they couldn't give low molecular weight heparin, for example. And yeah, I agree with Beverly with regard to antiplatelet agents. So we know out with hospital that aspirin reduces VTE risk by about 30% for long-term secondary VTE prevention compared to anticoagulation, reducing that risk by 80 to 85%. And aspirin probably has a similar bleeding risk to low-dose DOACs. So why would you do it? And I mean, we don't know that's true for the acute medical patients, but one could imply it. But I think potentially adding an antiplatelet as part of a randomized control trial to the sickest patients on ICU, especially because we know there is a risk of arterial thrombosis with COVID, is a really interesting question. But
no,
question.
No, and thrice no then from you as well.
Yeah, no.
Okay, just a few final questions on this one, and then I'd like to move topics. So we did have a question from a panelist about rumoured shortages of low molecular weight heparin. I don't know if either of you have experienced that or if you saw it coming, if that might affect your decision about DOAC therapy. And then the other...
Can I interrupt?
Please,
so yeah. I sit on Department of Health Committee. There are no shortages or anticipated shortages coming up. We seem to have adequate supplies. If we were to run into serious problems, then there is a lot of fondaparinux being stockpiled elsewhere. The issue was swine fever affecting all of the stocks of the pigs in China. And there were 560 million pigs in China, and about a third of them died due to the outbreak of swine fever. And so there just wasn't enough porcine intestine available to process. But I think they're back to nearly full stock now.
Okay. And the last question on this topic was about monitoring. So if we're letting these people go home for anywhere between 2 to 4 weeks, are either of you recommending follow-up blood counts, platelet monitoring, EGFR monitoring if it's borderline, or are you leaving that with primary care physicians? What do you think the role is for community monitoring in these patients?
I think it would be a bit harsh to leave something to the primary care physicians, but giving a week of low molecular weight heparin, no, we're not doing additional monitoring.
Ditto. Yeah, not doing any monitoring.
And if I stretched you to 4 weeks, as the NHS England guideline recommends, you would be happy to just prescribe that?
Yeah, so if you've been happy with it depends which drug you prescribe, but if you are once happy with low molecular weight heparin, with renal function and liver function in prescribing a DOAC or low molecular weight heparin on discharge, and you've got no reason to assume the patient's going to deteriorate, then I wouldn't monitor it. I think if the patient feels they are getting more unwell, having been discharged from hospital, they have to be...
The risk of hits with low molecular weight heparin is incredibly once a week, but it doesn't say that anymore from what I remember.
No, I think BCSH guidelines don't advocate any routine monitoring, do they, anymore?
Exactly.
So that's what most of us would go for in hospital, I think, and even outside. So, I mean, from emergency medicine, we prescribe extended courses for patients with lower limb immobilization in the community, and sometimes they'll be on it for 6 weeks, and we don't advocate any routine monitoring. I was just interested to know if you approach this any differently, but it doesn't sound like it. Okay, thank you. I would like to just move us on slightly now. So we've talked a bit about what we do when patients are coming up to discharge and they're going back into the community, but what about those patients who never make it into hospital? So there are a lot of those patients, aren't there, who will be diagnosed with COVID-19 or will have symptoms suggestive of COVID-19, and I'd like to talk about some specific groups. So if we start with those who are ambulatory, and let's say they have confirmed disease, but without any comorbidities in particular, what are your thoughts on the role of thromboprophylaxis for that group? Do you think there is any at all?
So I think that if they've got no comorbidities, they need to be reminded they needed to keep mobile and not to get dehydrated, but I see no indication for them to have thromboprophylaxis.
And Susie, have you had any questions along these lines?
Yes, and I mean, I agree with Beverly. I think the thing is, none of us have any evidence on the rate of VTE in the ambulatory patients who haven't yet made it to hospital. So it is expert consensus. It will vary. And I think it depends how unwell someone is. So if they're ambulatory and really pretty well, then and without comorbidities, then I'd agree with Beverly. You tell someone to stay well hydrated, mobile, and warn them of the different symptoms and to come into hospital if they deteriorate.
So, I mean, I meant to ask this in the topic before, but have either of you produced written information or guidance, or is there anything available from Thrombosis UK about the additional prothrombotic risk? Because I assume we've all got HAT leaflets and we give those to patients at discharge and we remind them about the risk going home. So we've been using those, but I wondered if either of you had developed bespoke tools.
So if you developed a tool today, July the 2nd, would it still be operational on August the 2nd? That's the problem, because the evidence base is changing so much. I think there's a lot of disquiet among the websites, among the patient groups, from those who've got prothrombotic states, because they're worried that they're going to get severe COVID and have worse thrombotic problems. And we have no evidence at all that that's likely to happen. And, you know, if I had somebody with antiphospholipid syndrome come in and they had required mechanical ventilation, they would be getting continuation of good anticoagulation. So I don't think that we should be doing any more than we're currently doing. I've asked my patients if they have a prothrombotic state and they're not on anticoagulation to give me a ring if they get COVID, so that if they do require hospital admission, I can talk to their team and say, hey guys, this one's a little bit sticky. Can you make sure they get good thromboprophylaxis? But otherwise, I don't see the need for more than that. And things are so fluid, you can't produce advice for patients that won't be out of date in a fortnight.
There's a challenge with diagnostics though, isn't there, about ambulatory care in the community. So some of these patients may get symptoms of COVID but then won't be tested because either the primary or secondary care facility is not testing at the time and is saying, well, we'll treat you symptomatically, your observations are reasonable, go home, ride it out. And I suppose then we're in a slightly sticky situation, aren't we? Not to, you know, apologies for the pun, but we're in a sticky situation because we don't have a formal diagnosis. We've got someone with known prothrombotic risk. You know, do those two things together necessitate intervention or action or not? I think we did have a question from the panelists that specifically highlighted, I suppose, patients with known prothrombotic risk. So those patients who've had a previous DVT but now off anticoagulation, those patients with active cancer on treatment in the community, those patients with a thrombophilia of some degree who then get diagnosed with COVID in the community. So can I ask you for your thoughts on those groups in particular? Susie, if we start with you, what would your advice be to someone with a known thrombophilia who then been diagnosed with COVID but told to stay at home?
So I think this is one of the times when all we can really say is individualized management. And to, you know, like Beverly said, for her patients to call her, I think we need to consider them one at a time, and that patient needs really good counseling, because they have to know that actually we don't know what the balance is. And I would worry about someone who had had a previous VTE who wasn't on anticoagulation more than someone who had inherited thrombophilia but no personal history of VTE. And if you want starting it, I would probably do 4 to 6 weeks of extended thromboprophylaxis for a really high risk patient. But I would want to do that with good counselling so that they understood that, you know, the risk benefit was a bit unknown.
Beverly, what are your thoughts?
So this morning in clinic, I must have had this conversation 3 or 4 times. And people very worried because they've got prothrombotic states about COVID. And I mean, the first thing is to look at them, and if they're young and they're not overweight and they don't have any other comorbidities, their chances of getting severe COVID are small. If they do get COVID, they haven't got an increased rate of getting COVID, and then the chances of getting severe COVID are small. And I would want to know if they got COVID, because if they did require hospital admission, I would want to make sure they got adequate thromboprophylaxis. I don't really want to give patients extra thromboprophylaxis if they're just going to have a little bit of anosmia and perhaps a bit of fever and then get better, because we're giving them something that's also got a bleed risk associated with it.
Yeah. What about, had a question from the panelists asking about mechanical thromboprophylaxis. So is there a middle ground with this assurance and hydration and mobilization to say you could get some stockings, or if you've got any other additional mechanical things, could you try those?
It's no, no, no. The stockings, there's no evidence that stockings are any benefit at all. If you can get the stockings on and struggle to get, you know, thick stockings on, you're probably mobile enough, you don't need them, and there's very little evidence they do anything at all. So no, intermittent pneumatic compression is fairly wonderful if patients are in hospital and mobile, but not stockings.
Okay, and time is flying, so I need to move through our agenda. I mean, the next group that everyone is interested in regarding ambulatory care and thromboprophylaxis or care in the community is those patients in care homes who are sedentary at baseline, will then perhaps get COVID and may be swabbed positive, again, may not even be tested because, you know, there's challenges with that, but certainly won't come into hospital for a variety of potential reasons. Maybe that's their preference or their family's preference. Maybe the hospital's at capacity. Maybe they're particularly frail and vulnerable and the risks of hospitalization outweigh the benefits. So what are your thoughts on assessment and prophylaxis for those groups? Because they are very, very tricky, I think. Susie, shall we start with you?
So it's a really good question, and it is one that we are being asked. I think it would be really important to try and get a trial in this area, because none of us know. We don't know out with COVID, let alone with COVID. If patients are unwell enough to come to hospital to be assessed, then what we had said was for ambulatory patients having been assessed in the hospital to do an individualized risk assessment, that if they have, and to consider extended thromboprophylaxis if someone has an additional risk factor. But that isn't based on evidence. We don't routinely do VT risk assessments in the care homes, and I haven't introduced that. We haven't introduced that in the time of COVID.
Yeah. I'm just seeing some chat on the Q&A that some areas are treating home outbreaks as if they were in hospital and are risk assessing and providing prophylaxis. So it's obviously an agile area, isn't it, where people are practicing differently. Beverly, what are your thoughts on this?
I think it's very difficult. So there is a little tiny bit of evidence that patients in care homes have a higher rate of VTE. There was a thesis recently examined and quite a few publications around that thesis, and it's soft evidence, but there is a suggestion. I think if we are going to treat people in care homes with equivalence to those in hospital, they should receive thromboprophylaxis if they get COVID pneumonia.
Yeah. It is difficult though, isn't it? I mean, we had a rising incidence of VT in some of our intermediate care and care home patients that we identified on root cause analysis just through the usual pathways pre-COVID, and that prompted us to look at the specific care homes that our hospital covers, where we use an electronic health record. So it was very easy for us just to transfer the risk assessment pro forma onto the health record in those intermediate care homes and start doing regular risk assessment. So we were doing that pre-COVID. Difficult to know yet if that changed during COVID, but it's something we'll be looking at. And risk assessment in care homes has been a hot topic for a while, I think. So all the more so now. But it's difficult to mandate, and of course that's I suppose a postcode lottery in my area. Some of our care homes are linked to the hospital, and that's what you get, and some of them aren't, and then you get a very different level of care if you're 5 miles down the road. So tricky, and I don't think any definitive answers on that one, are there?
No, but I also think within it, it's really important to remember how unwell is the patient with COVID, and how unwell are the patients when they're being kept at their care home rather than being admitted to hospital. So we've started to see patients for 3-month VTE review, and a couple of the patients that I reviewed on Monday had been unwell at home for 2 to 3 weeks, really more and more significantly unwell before they presented with COVID symptoms before they presented to hospital with a PE. But neither of them had additional risk factors for VTE. So actually, the fact that they had been immobile at home, dehydrated, unwell for the week prior to admission was the biggest risk factor, rather than an additional comorbidity that was known about. Whereas if you get better after 7 days, then your VTE risk may be low.
Yeah, absolutely. I suppose there's a question about the agents as well, isn't there? So there's another question from a panelist talking about linvoseltamab, heparin and DOAC therapy for patients in care homes. And of course, it can be challenging to arrange for regular injections in these patients, whereas oral therapy might be better tolerated. I don't know if either of you have a quick comment on that.
Is this the thromboprophylaxis still?
Yeah, so thromboprophylaxis in care home residents.
It's so for me, I find it a bit of a moral and ethical dilemma, and I think we are one of the few countries that left people in care homes when they had COVID, and I would have liked to have offered them equivalent care, although they weren't being ventilated. And I think that when we look back at this whole pandemic, the whole business around people staying in care homes and not being admitted to hospital is a sticky one and needs discussion.
Okay, well, we've only got 1 minute left, so I don't think now is the time or place for that. I would like to ask one last question, if that's all right, with the two of you in the last minute, which is about evidence-based medicine, I suppose. And Beverly, you alluded to it in your talk earlier. You know, the original definition of evidence-based medicine encompasses the published evidence, doesn't it? But also clinical judgment and patient values and preferences. You know, we're struggling with the evidence base, so obviously weight will be afforded to the latter two perhaps a little bit more, but they're very subjective and can of course be influenced by individual perception of risk. And I wanted to ask if either of you two, or how you think you have been influenced in terms of the way you look at evidence-based medicine and apply it to practice during this pandemic. Any lessons you've learned or any take-home messages about it?
I'm practicing medicine as in the time of William Osler at the moment, who was a wonderful Canadian physician who looked at the patients and he observed things and made judgments on that. So we've moved right back to that time. And before the pandemic started, I was hopefully an evidence-based physician, but the pandemic doesn't allow that. And that is the tension in medicine of the pandemic, that we've got all of this pathology with really very little evidence to tell us where to go.
Well, there is an absolute tension. There's also the usual traps, isn't there, of the appeal to emotion and don't just stand there, do something, and all of the caveats and the reasons that we've developed evidence-based medicine in the first place. You know, a lot of those things are coming back and we need to be wary of them. Last 30 seconds, Susie, do you have anything you wanted to add about that, about the application of evidence-based medicine in these challenging times?
Yeah, I mean, I'd agree with Beverly about the tension between the two, but and acting when there isn't evidence, following careful discussion with the patient. And then I think what we are obliged to do is collect the evidence. So collect our observational evidence, which we should be able to do within our own hospitals, and proactively push for clinical trials in this area, so that there is a period of time when we have to practice medicine in a non-evidence-based way, but that we move in a few months' time to doing it in a more evidence-based way again.
And I have to say, as a Brit, there is enormous frustration with the higher authorities that they would not let us set up trials in thromboprophylaxis very early on. The trials were ready to go in April and they were turned down. That's not good.
No, that's not good, but it's after 5, and so rather than end on a negative, if we end on a positive, I think the three of us would definitely agree that active research, engagement and participation in this time is absolutely vital, isn't it? And part of all of our duties as clinicians, not just academics, but everyone should be engaging in research or offering research opportunity to patients so that we can try and get answers to guide our practice and try and provide the best evidence-based care that we can. I think we are gone 5 o'clock, so I think we'll probably draw a line under it then. There's still over 200 people with us, so thank you very much for sticking with us. It's been great to have you. Thank you for the questions that have come through. We can try and address a few of those after time, just by text. And Joe will send a link out, I'm sure, to the guidelines that we've referenced, so that everyone has a copy of those. CPD certificates are available, so we'll make sure you all know how to access those. And as we said at the start, the webinar will be uploaded to the Thrombosis UK website, so you can revisit any aspect of it at your convenience. Lastly, just to say huge thank you, of course, to Dr. Susie Shapiro and Professor Beverly Hunt for participating and bringing their clinical expertise, their anecdotes of cases and their interpretations of the evidence to bear. It's been very useful. I've learned a lot. Thanks to Joe and Thrombosis UK for organising, and thanks to you all for participating. And we will maybe see you in the next webinar.